TopMedTalk.
My only task is here to introduce someone who needs no introduction. That's all I'm supposed to say. That's because I noticed that Mike Grocott is a personal friend of almost every one of you, shaking hands, hugging most of you. What is there to tell about this person? He lives in the New Forest, has 3 kids and a dog, and the kids are just as talented as both their parents. And he's a special person. He is involved in the board of almost any society in the UK that has to do with general anesthesia, with pain medicine, or with perioperative medicine. He has his own journal that he is editor of. He has his own research institution. And I forgot to tell you that he has a lot of experience in high altitudes. I don't know whether he's going to mention it himself, but this Sunday he and his family will be flying to India to do some high altitude trekking again. So I just hope that you would leave some room for the other speakers for the next 3 days, and please take the floor.
Thank you very much, Gerrit. I feel embarrassed. Welcome. It's really lovely to see everybody back in London, and I guess that as a starter for the Where Are We Now, it's great to have everybody back here. This is the 4th World Congress of Prehabilitation Medicine. It's the second one run in combination with EBPOM, so the Evidence-Based Perioperative Medicine Congress. The first World Congress of Prehabilitation Medicine was a relatively select group meeting in Montreal, hosted by Franco Carli. It was a wonderful meeting. The second meeting in Eindhoven was hosted by Gerrit Sluyter in the Netherlands. Much bigger meeting, really impressive program. We then came to London, for those of you who remember, to the British Museum in 2019, had a great event, north of 500 people, absolutely lovely venue. And we would have been going to Barcelona in 2020. Instead, we all got rather distracted and did whatever we did during all those lockdowns. And this is the first face-to-face meeting we've had since 2019. A little bit of a plug. I don't know if Bernard's in the audience, but the Melbourne team will be organising the 5th, so the 2024 5th World Congress of Prehabilitation Medicine in Australia, in Brisbane, on the 4th to the 6th of October next year. So look out for other materials about that and hope to see at least some of you there. Forgive this cliche. It's one of those annoying cliches that bosses say to you, and is probably not very good leadership. It does sort of imply that the boss is not very helpful and engaging. But I think this will not set the tone of my talk. I'm going to go a slightly different route today. I'm going to talk about problems. And I rather like this Albert Einstein quote about the value of exploring problems or challenges. And I think we have quite a few problems in prehabilitation, which may not be how you expected me to start. I think we have some existential problems in terms of defining exactly who we are and what we do. I think they're quite fundamental, and I think they're quite pervasive in all sorts of different elements, which may sound very negative, but actually I don't think that's the case. I think they're a symptom of success. It's a word that I don't think most of us would have heard, prehabilitation, beyond certainly about a decade ago, and wasn't in common use till even more recently than that. I think the problems are soluble, and I think most of those problems are really good opportunities for many of us in this room. So I don't think it's a negative story, but I think it's really worth exploring and teasing apart where we are. And I'm going to use as the framework this document, which I, along with many people in the room, were involved in putting together across 2018 and 2019, and was presented at the meeting we had in the British Museum in 2019. So this is the Principles and Guidance for Prehabilitation for People with Cancer. It was jointly sponsored by Macmillan Cancer Care, the Royal College of Anaesthetists, and the NIHR National Institute of Health Research Cancer Nutrition Collaborative. And I think it's been reasonably influential. We set out a definition of what we thought prehabilitation was, emphasised the potential benefits in terms of patient empowerment and quality of life, in terms of promoting resilience and therefore promoting recovery and improving outcomes, particularly in relation to surgery, but also potentially in relation to other cancer therapies. And then we touched upon this idea that there might be long-term benefits from prehabilitation through behaviour change that is persistent and impacts long-term health trajectories. Couldn't do a talk on prehabilitation without showing this, but I think it's a really important conceptual basis for what we do. So the notion that through an intervention before a treatment, we improve resilience, I think is probably the easiest way to describe it, but we talk about functional capacity or a whole variety of other variables, and that might be an exercise intervention, it might be a nutritional intervention, it might be a psychological intervention, or perhaps some other things. And then the notion is that therefore you withstand the physiological challenge of whatever the main treatment is, surgery being a good example, and as a consequence you recover faster and you're back to normal life more quickly. And there's the potential, of course, to intervene afterwards. And we tend to think of this more as a continuum of care. Cancer, again, being a great example, typically being marked by multiple treatments, so multiple opportunities to intervene with prehabilitation type interventions. We talked about a framework with screening of everyone to identify those at greater risk, more detailed assessment of those that are at risk, and then interventions, needs-based interventions prescribed across a hierarchical approach, and then a monitoring of outcomes. And we had this notion of universal interventions, targeted interventions, and specialist interventions. And universal interventions being simply something we could apply to everyone that might be relatively simple advice. So I was a champion of those. I went with June Davis, who co-chaired. We went around the country and promoted them. But I'm now seeking a suspension of disbelief, because what I'd like to do is pick them apart and see where we might have got things wrong, or we might improve them. And one of the reasons to do that is because we're planning to refresh these in the from the end of this year through to the end of next year. So we should have a new set of Macmillan guidance by the end of next year. And I want to start with some very simple questions. What is prehabilitation? How do we define it? What is the aim of prehabilitation? How is prehabilitation prescribed, and what is prescribed? And does it work? And I believe that the talk is not necessarily through the lens of a healthcare professional. Clearly, I'm a prehabilitation enthusiast, but I've tried to frame the talk as being reasonably from the perspective of either a patient, which many, if not all of us, will end up being at some point, or of a healthcare professional. So let's start with what is prehabilitation. These are two of the definitions that you might find. The first is from Julie Silver's very well-cited review article back in 2013, and the second is from the Macmillan Guidance. What I'd say about them is they are not definitions. If you read them and think about it, they're descriptions of something, but they don't clearly define what that thing is, what's included and what's not included, what the scope or the precise characteristics of that thing is. And without getting too complicated about this, definitions fall into two principal categories. So either definitions, so-called extensional definitions, where you simply list, which is what we've typically done. So, prehabilitation, what's that? Well, it's exercise and nutrition and psychology and a bit of behaviour, and it might involve smoking and alcohol. Or definitions which are so-called intentional, where you have a set of criteria. So you have necessary qualifying criteria and sufficient criteria to meet a definition. If that sounds a bit pedantic, I'll give you a simple example. You know that the giraffe is a mammal, and you know that the crocodile is a reptile, and you know that because there are a set of criteria. The giraffe is a warm-blooded vertebrate. It has fur or hair, it would also meet the criteria, and it produces milk to nurture its young. And the crocodile doesn't do any of those things. And we can clearly discriminate between mammals and reptiles. And I'm not sure we're quite as precise in our ability to discriminate between what is prehabilitation and what is not prehabilitation. So I'm going to throw out some possibilities that do not particularly, in fact, are largely not drawn from the definitions, the descriptions that I showed you a moment ago. I think it's individualised. I think it's prescribed, but we're not talking about prescription of medicine, we're talking about prescription of other types of interventions, often physical interventions. I think it is non-pharmacological, and all of these things are for discussion. It's often multimodal, but being needs-based, it may be that you only need a unimodal approach, but it's often multimodal. It crucially involves supported self-management. So it's somewhat different for giving a drug or doing what I do most of my clinical activity on intensive care, which is doing things to people who are unconscious on ventilators and giving them drugs. It involves a partnership between the patient and the healthcare provider. The result of it is that it promotes resilience, and that promotion of resilience is in order to aid the withstanding of some potential harms from a future treatment, and it's enabled by behaviour change. Those, to me, are a set of candidate criteria that might describe what is and what isn't in prehabilitation for discussion. I can see Ross sighing and looking pensive, so I anticipate a question later. If you do the inclusional approach, we end up with this. So we list exercise, nutrition, psychology, behaviour change, smoking cessation, alcohol cessation, and potentially other interventions, which I'm not so sure are prehabilitation. But there's a blurring. So some folk would put anemia management in because it potentially promotes functional capacity. But then that is pharmacological. And if anemia management is in, then why isn't better management of diabetes? In which case, why isn't cardiovascular disease management and respiratory disease management? And suddenly we've lost any sense of scope at all. So I think there's an argument for constraining this definition to the non-pharmacological elements of promoting resilience. What is the aim of prehabilitation? Well, preparation for a variety of different insults, and we've typically focused primarily on cancer and surgery for cancer. But actually there's plenty of work, and there are people in this room doing work on non-cancer surgery and on non-surgical cancer therapies, and I've listed a variety of non-surgical cancer therapies there, all of which there may be value from prehabilitation. And in fact, basically any intervention that may cause harm. And I was recently in Milan for the European Rheumatology Society, and they are now starting to look at prehabilitation before some of the interventions that they give, some of the pharmacological interventions they give, to promote resilience in exactly the same way as we're thinking about it. And I think we're seeing it across more and more different specialties. Looking at it from a slightly different perspective, what is the aim of prehabilitation? Well, I've touched upon these already. So empowerment and quality of life. So, and this is the only part really when I'm going to touch on the evidence. I think, no, put it another way around. I can't think of a study where the result is not improved patient satisfaction and where it's measured improved quality of life. So I would be reasonably confident to say that prehabilitation, not terribly surprisingly, because usually exercising, eating well and having good mental health makes you happier in normal life, never mind before treatment. But I think prehabilitation, that all the evidence that I've seen suggests that it improves patient satisfaction and quality of life. I think we've jumped quite a long way from where we were in 2018, 2019, and there's now an increasing amount of data that it promotes resilience in terms of improved functional capacity measured in a variety of ways, and I'll come back to that again in a moment, and therefore promotes recovery. So I think we've got a number of studies, particularly related to surgery and particularly focused on exercise, that suggest that if you make people fitter or you use different exercise interventions before surgery, you can reduce complications measured in a variety of different ways. And I think we will be increasingly confident that there's a signal there. But it is surgery and it is exercise. It's not necessarily multimodal prehabilitation, and it's not necessarily the other contexts where we might use prehabilitation. And from my perspective, I think we still have very little data about this promising notion that we might be able to change behaviour, alter health trajectories in life, and therefore improve long-term health. We may improve long-term health simply by reducing complications, because there's a known association there, but whether we alter overall health outcomes as well, less certain. I think we're also beginning to understand that disease modification is possible, arguably common as a result of prehabilitation. There's some really interesting work in the cancer space on tumour regression that some of you have seen, and I certainly haven't seen any data to contradict that, and it's entirely consistent with the animal data, so I think it may be beneficial for at least some types of cancer where that's been looked at. I think arguably there is data to suggest it may be beneficial in terms of reducing systemic inflammation, and that may be one of the mechanisms for reduced complications after surgery. So I think as a disease-modifying intervention, I think there's a reasonable case. And I think a lot of the work, we're going to hear about some of it in the next couple of days, but a lot of the interesting work in the coming years will be about better understanding what those mechanisms are, and therefore understanding the different interactions between the interventions within multimodal prehabilitation. So as a good example, the interaction between different types of nutritional and exercise interventions. Prescribing prehabilitation. So we have this framework of screening and assessment for different domains. So you can think of a little matrix of screening and assessment tools: exercise, nutrition, psychology, maybe behaviour change separate, maybe it's not. I'll come back to that as well, which looks really neat when you put it in the guidelines, but I'm not sure it's quite as neat when it encounters reality. So some people, for example, the people where I work, really like cardiopulmonary exercise testing, and other people, for example, the people where Franco works, really like the 6-minute walk test, and yet other people like sit to stand or grip strength or a whole variety of different measures. And I wouldn't like to say for sure that we know right now which of these will be shown to be best in the long term for the assessment of exercise. I think we've got some interesting screening tools. I'm not going to go into that in detail. And I also don't know what the role of these types of devices, these wearable devices might be, whether we can get most of the information from a period of time before whatever the intervention is that will allow us to guide prescription, or whether we actually need these face-to-face encounters with exercise tests or 6-minute walk tests or the like. So I think there's quite a lot of work to do there. I'm neither an expert in nor would comment on these various different tools, but I would comment that they seem to be used interchangeably as screening and assessment tools, which seems problematic in some respects, and we don't seem to have a consensus as to which is the best. So we've got a variety of different tools, some of which will have quite a lot of overlap between them, so they're drawing on the same underlying variables but producing subtly different scores. So I don't think we've completely got sorted how we screen and assess for nutrition or psychology. And I'm a bit troubled about some of the issues around needs-based interventions, because we've got this lovely pyramid of universal for everyone, targeted for those at higher risk and specialised for those at highest risk. But I'm not sure universal is really prehabilitation. Because if what we're doing is simply advising people to follow the WHO guidelines, which are supposed to be the guidelines for all of us every day, and I won't embarrass myself or anybody else in the audience by asking people to stick their hands up who actually do manage to do 150 minutes of exercise per week reliably. I suspect at least some of us don't. But I'm not convinced that universal is prehabilitation, because it's a promotion of activity, and the promotion of activity may be quite distinct from the benefits of exercise. And I'm not sure it's going to be helpful for us, because if we want to be successful in delivering these interventions, we need to look at business cases and how they get funded. And if part of our argument is actually you can do this anyway by advising people about activity, that will be the lowest common denominator that the managers tend to focus on. So I'm actually not sure whether the universal approach, whilst it's important to give general health advice, whether it actually constitutes prehabilitation. I've touched on this already. It is important to distinguish, and it's self-evident to most in this room, but distinguish between activity, which is what we all do all the time, and exercise, which is a structured, goal-driven subset of activity. And the evidence we've got is almost exclusively from exercise, as distinct from activity, and it's very structured exercise. So the protocols are pretty precise as to what you do. We largely know that those type of interventions work. We don't know that simply the promotion of exercise will be anything like as effective. It might be, but I don't think we know the answers. I don't know which of these different type of interventions is effective, but I do believe that most of the data is for aerobic interval HIIT type interventions. It makes perfect sense that strength might be beneficial, but there's remarkably little data from my perspective to support that, so I think that is worthy of challenge. And I'm not sure whether it matters or not what the modality is. So does it matter whether you do an equivalent amount of exercise, swimming, cycling, or running, or is there actually any particular benefit to, for example, being on a cycle ergometer and building up muscle bulk, and is the muscle bulk part of the mechanism of benefit, which some would argue? There's a lot of things I don't know. Psychological support or behaviour change. Are these all one thing that we kind of lump together, or are they quite distinct? Because I think we've got specific psychological interventions, so different types of talking therapy, very specific therapies such as eye movement desensitization for PTSD and anxiety. And then we've got a whole load of interventions which are essentially behaviour change interventions, so the use of SMART goals, diarying, different types of nudge techniques, different approaches to rewards. And those look to me like, if you like, the wrapper that promotes behavioural change. So they are supportive of the exercise and nutritional changes that we want to encourage, and potentially the psychological interventions we want to encourage. I think I'd make a case they're distinct, but I'm not a psychologist, and maybe we should be lumping them together. There are a lot of issues about interactions of interventions which I don't think we understand at all. And I'm not about to depart into a research geek 5-minute departure. So these are complex interventions, and there are people who will wax lyrical about the MRC framework for complex interventions, but it's a pretty simple notion. It's the notion that the different components of intervention interact together, and they don't necessarily consistently interact together, and also that they interact with the environment in which they are taking place. So and we know that for something like exercise. So if the intervention is simply described as exercise, that doesn't characterise all the nuances that we understand about in-hospital exercise, home exercise, exercise near the home in a supervised environment, virtually delivered exercise. So prehabilitation is very clearly a complex intervention. And the reason complex interventions are complex is because of the nature of the interactions. So they're not necessarily linear. It's not necessarily that you do more exercise and more nutrition will universally be good. There are clear, non-linear and unpredictable relationships between different parts of interventions. I'm not going to talk at length about implementation, but as I think we move from the could it work to the does it work, as in the efficacy to effectiveness phases, which I think we're well into the effectiveness phase now. There's lots of reasonable, not big, but reasonable sized clinical studies suggesting clinical benefit. We've then got the challenge of how we implement this, because it's complicated, it interacts with a lot of different components of the healthcare system, all the elements of service delivery, of pathway re-engineering. If you think of the surgical context, prehabilitation sounds, perioperative medicine, pre-assessment, they're kind of all the same thing, but actually there's some really important distinctions. If you want to get in early to screen for your prehabilitation interventions, for your needs-based prescription, then the pre-assessment clinic a week before surgery is not going to solve the problem. So we've got some complex clinical pathway design issues. There's a lot of challenges to business case, and I suspect much of the chat in the breaks will be about how did you get your business case to work or not. We talked about personalised prehabilitation care plans and Macmillan guidelines, which is a lovely idea, but I don't see those flowering across the nation at the moment. There are issues around workforce, who should be doing this, what's the governance, what's the professional indemnity, for example, of different folk who might be delivering different elements of prehabilitation, including the prescription and delivery. And there are obviously all the usual issues we have for clinical services around quality assurance, quality improvement, and clinical leadership. And I'm going to close by saying a few comments about the money, because without understanding the money and achieving a successful business case, we're not going to manage to implement these types of interventions. So I think most of you are familiar with this notion, the notion of the triple aim, so having a responsibility for improving the care of the patient in front of you, which is what we've all grown up with as healthcare professionals, but also thinking more generally about population health, public health, and thinking about the importance of value. So if we're over-generous over here for a particular intervention, we're going to lose the option to do an intervention over here. If we have too much hemodialysis, we're not going to be able to do prehabilitation. If we have too much prehabilitation, we might not be able to do surgery. So those decisions and responsibility for them is very important. I quite like this notion of the quadruple aim, so also improving the quality of the workforce. And for those of you living and working in the UK at the moment, I suspect that will particularly resonate. If we're talking about value, it sounds on the face of it pretty simple. So the notion of outcomes per unit money, so per dollar, pound in. But actually, it's not really so simple. I think we all understand the notion of cost-effectiveness matrices. So if it's more effective and more and less costly, that's great. It's an easy win, but often it's not quite that clear. And I think the business case context and the business case time frame is really difficult. So drawing on the UK context, we often have to make our business cases at a hospital level. And yet a lot of the benefits accrue to the regional health system. So it's very different if you're trying to justify something to what we call an integrated care system across a whole region as opposed to a hospital, where the hospital, if you think of elements of prehabilitation, which I haven't really touched on so far, but part of the screening and assessment can sometimes result in a decision not to have the subsequent treatment because the patient is not sufficiently resilient. And not having the treatment means nobody's going to pay for the treatment. So you may intervene to prevent harm here, stop them actually having the definitive treatment, and lose income for your institution, which may not be popular. And finally, the issues of incentivisation, which kind of overlap with what I've just talked about. If you're in a fee-for-service environment, then almost invariably doing more is going to be good because it brings more money into the institution. And I hope this rarely happens, but it does mean that if patients accrue complications, depending on the payment mechanisms, that can, on occasion, be beneficial to the institution. That can't be in the interest of the system. In contrast to things like the capitation type approach, where money is allocated across a region per patient, and everybody's interests and incentives are aligned with doing the right thing. So I'm going to leave it there. I hope that was helpful in raising some questions about what comes next. I apologise for not giving you more answers, and I'm really looking forward to the discussion. Thank you very much for listening.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.